I'm going to take you right back. First of all, I come from a different direction from Sophie. I'm not a medic, I'm not an academic in sociology or anything like that. I was a research scientist at the beginning of my career in 1968, got a PhD in Queen's, Belfast. And then I got a job at what used to be called, in one of its incarnations, National Vegetable Research Station, and then it ended up as HRI Warwick, or Warwick HRI. And I remember in 1972 or 73, there was something called the Rothschild Report. And the Rothschild Report, it was a green paper on what should happen with agricultural and horticultural research. I'm a botanist, by the way. And I remember my boss saying, this is absolute disgrace. Who do they think they are? We know what's good for them, and them were the farmers. And I couldn't understand that because my father was a research scientist and practical research was his job. So when we're talking here about PPI, you're 50 years late, frankly. I haven't done any research in agriculture. I've been to Egypt as a consultant. I've had PhD students from Mexico, been on the fields, and it has all been two-way, reciprocity. And the reason for this is, it's not in the books. The farmer's got a field, something goes wrong, is there every day. And that's really what PPI is about. The people who have diseases or problems, health problems. And if I could put a plug, please, for carers, I like to consider patients as a dyad with carers. I don't think they're separable because the carer knows what goes on with the patient and the patient knows what goes on with the carer. So there's a fountain of information, a mine of information there that can be tapped and should be tapped. Engagement. That's a buzzword these days. I heard, well, it's on the notice board out there, engagement, but it doesn't say actually what it is. And then there is I heard a police officer in one of their little crises talking about we must engage with the public. So you end up, who's saying exactly what that is? And for me, it's getting away from this barrier, this division between research on the one hand, the health service and the public. They're all part of one thing. Am I? Right. So why digital technology? Why are we bothering about that? Why don't we just go back to pens and paper? Well, first of all, it's an alternative to traditional ways. It's not a replacement. There's sometimes when paper's good, and there's sometimes when digital is just as good. But there are other times when digital is definitely better because it can do more things, do them cheaper, and other things. It makes things possible which you wouldn't really be able to do. Digital does things better. But it also enables tasks that you'd like to do, but you couldn't do with traditional methods. If you go to the EHI conference in Birmingham in November, the things they do in terms of making processes possible, like audit trails, from the time you see a consultant to right the way through the hospital, it's all there. You couldn't do that with paper. And there are things that, if I think about Rumsfeld, Donald Rumsfeld, there are things we don't know, and then when we use digital technology, we find new uses that we never even dreamt of. Would you believe that a watch is going to be a heart monitor 50 years ago? Would you believe that a telephone is used to take cameras? So there is an unknown, we don't know about things. So those are the, for me, the reasons. There is also the research pathway. And I don't think patient and public and care involvement is something that is applicable, the same patient-public care involvement is the same at each stage of the research process. There are the patients and the people and the public are there, they have the experience to identify a need, which the clinicians may know nothing about. They are experts on their bit, but there's a dimension of the people who actually use it, call them clients if you like. There are people who help develop a research proposal. So the first two are really ideas, people. I like to be in at the first two. You need to obtain research funding, and it's at this stage, once you've received research funding, that participation at the moment is generally where it comes in. In other words, people have got together, they responded to a call for research, they prepared a research proposal, and they've got the money. They didn't have any money before to pay for public involvement, because money is tight. So it's at that stage, quite often, people get called in with a project that's already been developed. But there is a stage, research is iterative, it goes round and round and round, you find out one thing, you ask questions, and you go off in a slightly different direction within the strategic parameters of the research proposal. You carry out the research. That, I think, be careful what I say here. I was going to say there's some people, you say ask a question. It's not always easy to ask a question. You say to the public, I want you to give me an answer to this, and they don't know what you're talking about. It takes a certain skill to be able to analyse something and put it in the form of a question. And the questions are what research is about when you're doing it all the time. You have these meetings and something's happened or it hasn't happened, and that's when you start asking the question, what, why, when, how, if. It comes to the stage of analysing, evaluating and publishing. I don't think really the public can be too involved in the statistical analysis. It's a very complicated subject. You've got experts in it. Let them get on with it. They know far more about how to do this, how to evaluate the data. Publication, the public participation can, oops, what did I do there? They can help publish data, and there are lots of different sorts of publication. There's a standard one where you write a peer-reviewed paper, and it's either gets accepted or it doesn't. But there's all sorts of things. Communication at the moment is expanding at a fantastic rate, whether it's television or whether it's CD-ROMs or whether it's Skype, all these things. There are different ways of publication now. Even newspapers, we've still got them. There's a lot of stories that could be told, but sad to say, a lot of them are not. There are good parts in some papers, but generally the public would know a lot more if it was published in a more easy way, receptive way. And disseminating findings, research is never finished until you've actually published the papers and disseminated the findings. And then, of course, you've got to implement research into practice, and that was really what Sophie referred to, the Research for Patient Benefit Programme, which is National Institute of Health Research. I was on the review body for that for 5 years. There were two reasons that research proposals, main reasons, that they either failed or they didn't get funding. They didn't get funding quite often because they didn't say, when they got all the data, they didn't fill in the loop to the implementation into healthcare. And if that wasn't there, it didn't get funded. I forgot what the other thing was, so we'll ignore that. So, just to go back a step, and again this goes back to what Sophie was saying, PPI, and don't do anything to us without us, experts by experience. And that is what I used to call sort of grey information, because it's not validated, statistical, tested RCTs and things, but it's information that's there. And Sophie's got a project where we're taking all the sorts of information you can get, wherever it comes from, to put it together and see what can come out of it. So the reason I say they've got different experience and perspective that qualified professionals aren't in a position to have. They may have, but they may not. And it is key for the development of the NHS, continuation of meeting the needs, that this other experience gets built in. They have a very good idea of what is needed in healthcare. Why can't we have this? Why can't it be done that way? And that gives the digital people an idea. Can we pick this up and run with it to make it into something that is going to be properly useful? PPI ensures that the outcomes are relevant. I'm a bit of I sit on the fence a bit. There is research that may not benefit people directly, but things come out of it that later on do benefit them, so I'm not totally hard down. It used to be called research and development, you know, the skies research and development, people doing the hard work. It's a grey area between them, but we do have to keep our eye on the ball to ensure the outcomes are relevant, and with a shortage of research funding, that's where it's going to go. There are other sources of funding for the blue skies research. And the role of PPI, which I said at the beginning, is it changes, I think, in the research pathway. Ideas at the beginning. Research is, from the beginning, that's the idea stage. Someone says, why not? And everyone says, why not? We haven't thought about it, so let's get on with it. And then it goes right through, and with a bit of luck, it'll be part of the national health care. We are increasingly being promoted, asked to do self-management. Don't smoke, don't booze, don't eat too much saturated fat this week, or it doesn't matter the next week. But there are behavioural changes that would benefit us. There's no opportunity really to take those through in the real life of the NHS. There's just too many of us, and behaviour change is difficult. Digital can do that by taking it into the home environment. I road tested the Big White Wall programme, which is to do with, let's call it emotional problems. I don't like the word mental health. Emotional problems. And I think it's very good. It's written in a language that is respectful without being posh. And it comes back with very positive messages. Why don't you try this? Why should you try that? So if you take something like emotional health, it's still a taboo subject. The word mental is still a taboo word. So someone who's got a problem would probably rather do it at home, where he's on his own, and it's private, anonymous, and make progress that way. If he used to wait for a consultant, it might take a year. You know, go to IAPT, it took 6 months, easy. So enabling things to do that couldn't realistically be done, but do need to be done. There are the educational things. These days, when my brother had his chemotherapy, I looked up on the internet what these things were. I didn't have to go to a medical library to find out. So information is much more available. Same about medicines, about health, and about well-being. And then finally, which I think is something that's going to increase, is virtual teams. I spend a lot of my time on going to research meetings. To get to hear from Leamington takes at least an hour. If we want to go to Birmingham, I allow 2 hours. So you have a 1 hour, 2 hour meeting. It's an awful lot of travel time in terms of the actual meeting. Now, I once went to Birmingham for a half an hour meeting. It took me 5 hours. That's absolutely balmy. They could have had, if we had a virtual team, we could have got through the same information. So that is one example. One of our research projects, ChemoBrain, I'm referring to my brother because he had cancer 2 years ago, and we've got a program, a research proposal being built up on the effects of post-chemotherapy treatment on brain function. We've got people in America who talked about this. We can have a teleconference, but teleconferences aren't the best way of doing it. And I reckon there must be a way, I don't know what the way is, where you could have a virtual thing where you could sit down. When you need to meet in person, meet in person. When you don't, you have the virtual thing.